Hello, welcome, and thank you for joining this afternoon. This is the first in our second series of suicide prevention webinars of 2021. So we're really pleased to welcome you here today. For those of you who don't know me, my name's Karen Lascelles. I'm nurse consultant and I work with colleagues in leading the suicide prevention agenda in Oxford Health. I'm really pleased today to welcome Carl Marlow, our Chief Medical Officer, who's going to sort of chair the afternoon really, and also Professor Keith Horton, who many of you will have heard before at previous webinars and conferences and so on, who is going to give us a national update really of important information around suicide prevention. Then I'll go on to give a bit of a local update. And we're really keen as well that we use today for a good question and answer session to open up this series of webinars. So with that, I will hand over to Carl, who's going to say a few words first. Thank you.
Thanks, Karen. It's fantastic to be here and really grateful for the end of the day, people joining us on the second day of winter. So we've got slightly going into winter, we have these opportunities for these seminars. I think it's really important that as a mental health and community trust that we lead the agenda, especially as we have individuals like Keith who've not only got a national profile, but an international profile as well as an expert and authority in this field. We also in Oxford Health, we are part of the Emergent Integrated Care System, which is the system that provides services across Oxford, Buckinghamshire and West Berkshire. And we have a role to host seminars like this, host events like this, which goes well beyond our own boundaries and the services that we provide, to also open this up to partners within Oxford University Hospital, our GP colleagues, our social care colleagues, our local authority colleagues, and also patients and users of our service. So I'm delighted that we've got some content today, which is looking at how we look at our strategy involving those who use our services. The other area I want to just highlight from an Oxford Health point of view, as we have a leadership role within the system, is within men's mental health. And we are supporting organisations such as The Hill, which is an innovation centre across Oxford University Hospital, Oxford Health and Oxford University in digital innovation. And we're particularly interested in how we look at access to services which can make a difference. So today we have a wide overview and we have some specific areas of intervention which potentially can make a difference. This is not just about us talking about what we can see, it's about what we can do to make a difference, and that's where the strategy comes in, and that's where the clinical interventions are relevant and evidence-based. On that note, I want to hand over now to Professor Keith Horton, who will take us through the next bit of our session today.
Keith, you're muted.
Sorry about that. Thanks very much, Carl. Thanks for the introduction. I'm going to briefly touch on three topics of particular relevance to suicide and self-harm, which I hope will be of interest to you. The first is a new report on from the Office for National Statistics on suicides nationally in the early stages of the COVID pandemic. The second item is about the online safety bill, or harms bill as some people refer to it, and its relevance to suicide and self-harm. And then finally, I'm just going to briefly mention a report on suicide in healthcare workers, with a particular focus on suicide in nursing staff. So if I could have the first slide, please. Okay, so this is a report from the Office for National Statistics on suicides that occurred in England and Wales in the first few months following the onset of the pandemic, or more precisely, when we went into lockdown and shortly afterwards, namely April to July. This has been a bit delayed because of delays in deaths being registered, particularly in coroner's inquests. So this would have come out a few months earlier otherwise. Next slide, please. This slide shows suicide rates over the past 5 years for the months April through to July each year. And you can see that shown in maroon is the suicide rate for 2020, the first few months after we went into lockdown. And you can see that there's a marked decrease. There was a marked decrease in suicides overall, but this was mainly because of a decrease in males, a significant decrease in males. In females, the rates dropped slightly, but not to a significant extent. Next slide, please. This slide shows figures by age groups, and you can see across the 5 age groups shown here that suicide rates decreased in all of them during these early months of the pandemic, but the differences were only statistically significant for younger age groups, 10 to 24, 25 to 44, in whom they were quite marked. So it was particularly in younger people that suicide rates decreased. Next slide, please. And this finding is sort of in keeping with finding of a study which I think I presented at one of the earlier webinars, which was about suicide rates in a large number of countries during the early months of the pandemic, 21 countries altogether, but 35 regions or countries were represented. What was done here was that the actual numbers of suicides, and this was based on real-time surveillance data, the sort of data that would be collected in this country through police, and comparing the actual numbers with what would have been expected based on pre-COVID figures. And it was really a quite marked finding that no country had a rise in suicide rates during this early period of the pandemic, which is extremely interesting, as there were some dire predictions at the beginning of the pandemic about what was going to happen with suicides. Some people even predicting a greater increase in suicides than there were deaths from COVID. In fact, in 12 of the countries, suicide rates actually decreased. I should mention that within these data were data from the Thames Valley area, which includes Oxfordshire, Berkshire, Buckinghamshire, and Milton Keynes. Next slide, please. I'd now like to, yes, can you jump over this one? Next slide, please. I'd now like to mention the online safety, or what many people refer to as the online harms bill. And this is about possible restriction of harmful information being put out on the internet. I mean, this could be referred to harms of various sorts, including terrorism, for example, but it is of particular relevance to suicide and self-harm. Next slide. There has been some studies done on internet access in relation to both suicide and self-harm. And in this review, which we were also involved in, it showed that internet sites were often accessed by people prior to self-harm, and I'll show you a bit more on that in a moment. of particular concern is that there are quite a lot of what we call pro-suicide sites. In other words, sites which actually encourage suicidal behavior and self-harm. And these are very easy to access. And detailed information on methods of suicide and self-harm, as many of you will know, are very easily available on the internet. I mean, there's been a lot of debate about whether social networking sites may be helpful or harmful in relation to suicidal behavior and self-harm. And I think the evidence is that both apply. In other words, it can be harmful and can encourage self-harm depending on the nature of the communications, but it also can be helpful for people and provide support for people who are troubled and including those who are troubled by thoughts of self-harm or actual self-harming behavior. Next slide, please. With regard to evidence about internet use prior to suicide and self-harm, for suicide, the National Confidential Inquiry a few years ago published a report in which it was indicated that nearly a quarter of young people who died by suicide had accessed the internet shortly prior to suicide. But more specifically, in this second study, which was from Bristol, it was shown that a quarter, or 26%, of 8 to 18-year-olds who presented to hospital with self-harm had accessed the internet beforehand. Importantly, most of these were researching methods of self-harm, and particularly important was the fact that those who'd accessed the internet in relation to self-harm or suicide had higher suicidal intent. In other words, they scored higher on a measure of intention to die. So there's pretty strong evidence about the relationship between suicide and next slide, please. So as many of you will know, we have a draft online safety bill going through Parliament. It's an extremely complicated bill in many ways, and it's particularly challenging. Can I have the next slide, please? This slide summarizes the key provisions in the bill, and it's aimed at trying to prevent harms of various kinds to individuals in the United Kingdom. So one part of it is that all illegal content, and that has got yet to be decided what that is, should be removed from the internet. There are specific provisions for under 18-year-olds in that harmful content which is judged that it might be harmful to young people should be removed. And in addition, that information that may be harmful to adults might also be removed. So there's illegal content, and then there's not illegal content, but harmful content. Next slide, please. So that illegal content would include material which intentionally encourages self-harm or suicide. And this is already illegal under the Suicide Act of long ago as 1961, aiding and abetting suicide. The Law Commission is working on a new offence of encouraging people to self-harm as opposed to specifically suicide. Next slide, please. In terms of content that is harmful to adults, it will be any information which might cause significant adverse effects, both physically and psychologically or psychologically to adults. And it includes information which could be assumed to particularly affect people with certain characteristics, which makes them more vulnerable. So I guess this will include people with mental health problems. And it can also apply where there are specific communications between individuals where one is seen to be trying to harm another individual. Next slide, please. So this complicated process is going through the parliamentary passage. It's really at the second stage shown on this slide. I mean, the particular challenges with this are about information, particularly harmful information, as opposed to illegal information. There is the question of, you know, will a bill like this, if it's finalised, will it in any way contribute to some, limitation on individuals' ability to express themselves? Will it interfere with, communications between individuals, which possibly might be seen as helpful for some people and not for others? It's going to be very challenging and really important what we end up with, and I suspect what we end up with will not be the same as what we have in 5 years' time, and I think it'll be an evolving process. But I think the important point for clinicians is to just be aware of how important the internet can be for both self-harm and suicide, and that nowadays questions about internet access, I think, should be part of any psychiatric assessment, not just of people who've self-harmed, but it's important to know the sort of materials that people are accessing, which might put them more at risk. And then my last slide is about some recent data. So if I can have the next slide, please. That have been published again from the Office for National Statistics. This came out very recently, and it was about suicide in healthcare occupational groups. And the key findings really are put out here, and that is about the risk of suicide in female nurses. So between 2016 and 2020, 150 female nurses were recorded as dying by suicide in the country. Importantly, female nurses were the only occupational healthcare group with a suicide rate that is significantly higher than the suicide rate for all females in the population during the same period. And sadly, this is virtually an identical picture to the preceding 5 years, 2011 to 2015. So this is obviously of particular concern. During the recent 5-year period, 59 male nurses died by suicide, and their suicide rate wasn't different from that of males in the general population. So there is a particular concern about suicide in female nurses. So I'm going to hand over now to Karen, and I think she'll be picking up on this specific topic as well as others. Thank you.
Thanks, Keith. Yeah, I just want to pick up on Keith's last point. Perhaps that's how I can start some of the aspects I wanted to share about our local work. Obviously, it's a big concern that female nurses particularly are identified as an occupation at higher risk of suicide than the general population, one that we're all concerned about. And NHS England Improvement nationally have funded us at Oxford Health in collaboration with the Centre for Suicide Research to undertake some research looking at nurse suicide. This involves a systematic review that's being led by Keith, myself and Sam Groves, who's a researcher doing all of the work really. And so this is looking at the international literature since late 90s actually, when Keith last did a systematic review around nurse suicide. The purpose of this is to really understand the characteristics associated with nurses that end their lives by suicide, with the ultimate aim of informing future research so that we can develop interventions and resources to support nurses and to reduce and prevent suicide. Now, this research involves a couple of other strains, one of which is looking at the media reporting around nurse suicide. You will possibly know that media reporting is something Samaritans are really quite concerned about, because historically there has been very insensitive media reporting, and Samaritans have done an awful lot to try and improve that by introducing standards. We've partnered with, well, Keith has partnered with Samaritans, and we're making use of that partnership to look at the way that nurse suicide has been reported in media, again to see whether there's insensitive reporting and to see if there's work that needs to be done to improve that, so that nurses aren't insensitively exposed in the media in any way. And we're also looking at existing self-harm monitoring databases to help with this work, to try and understand characteristics that might lead to nurses self-harming. And as I say, the aim of all of this is to move on to more intervention-based research so that we can support nurses in the future. Now, I think it's probably important for me at this point to say that we all know that in suicide prevention of mental health problems and enhancing well-being is really important. And I think for all of us and all of you as healthcare professionals, taking care of your well-being is really important in the overarching endeavour to stay well and reduce and prevent suicide. So please make use of the intranet and all of the well-being resources that are there to help us, maintain a good level of well-being. So back to suicide prevention, I wanted to share some of the other local work that's going on. You will know if you joined earlier webinars this year that we did some research here at Oxford Health in partnership with Rachel Gibbons around the impact of the death of a patient by suicide on staff. We developed a resource for psychiatrists and we will be sharing a link to that. And we are in the process of amending that guide to be more inclusive to all mental health professionals, further to the second study we did on mental health professionals. Now, actually, people's responses are really quite similar, and what the support that people want is quite similar regardless of discipline, but this is something that will be available. There are two quality improvement projects underway in the Trust, one looking at suicide, not just suicide, looking at risk assessment and documentation and safety planning, and one looking at family involvement. Both of these are really, really important to suicide prevention. This work will be involving teams across the Trust, utilising quality improvement methodology to make improvements that eventually we would look to spreading further afield across the Trust. Associated with this, we are going to be introducing a slight change to the Care Notes risk assessment tab in the risk summary box, which will become a risk formulation box, so that it's more conducive to supporting clinicians to actually formulate risk and be able to document that formulation in a straightforward way. I'm going to move on in a second to the forthcoming suicide prevention strategy, but before I do that, I just wanted to touch on the earlier strategy that's now sort of come to an end as we move on to the new one, and some of the main achievements from that, one of which is in relation to safety planning. Now, many of you, if you're frontline clinicians, will be involved each day of your practice in safety planning with our patients and service users. And this was a key component of the previous strategy to improve training, to develop guidance, and to get it into our language, really, of safety planning. And that's something that I think we have seen. And certainly the audit carried out by Emma Lofthouse and colleagues has demonstrated that across the board our safety planning practice does seem to have improved quite a lot. We've got work to do to continue to improve it, and another addition to the Care Notes risk tab is that there will be a safety planning component to that, so that the safety plan will be more accessible to clinicians. But I think all credit to you as our frontline staff to have made such improvement to safety planning across the board. You know, it's a real achievement, so thank you. I also wanted to touch on the family liaison service that has developed over the last year. This is about supporting families after serious incidents, including the death of a patient by suicide or any other cause. This is made up of a team of sort of senior and experienced clinicians who work very closely with the SI team, but are not involved as an SI author, who support families both following these serious incidents and throughout the investigation process. It's a service that will continue to evolve and mature, but one that we are, you know, really glad to have, and actually also really pleased about the approach we've taken in having a team of practitioners that can work together to improve services for families. And lastly, the carer support group on the old strategy, we developed a carer support group specifically for carers of loved ones who may be at risk of suicide and who may struggle with self-harming and suicidal behaviours. So this group is quite well established. And if you do have any people on your caseload whose carers you think may be interested, do let myself or Di Hilson know, because you know, we have scope to invite more people to that group. But these are things that have become established and sustained as a result of the last strategy. I just wanted to touch on to the new strategy. Katrina, if you could share the slide, that would be great. Thank you. Now, this is in its very early stages of development. The infrastructure to support this strategy will be a small steering group and larger reference groups that feed into that steering group. We're very keen as well to ensure that we have a very robust lived experience component. And the slide that we're going to show, is it going to come up, Katrina? Not to worry if it doesn't.
I'm trying to get it.
Get it up. Well, perhaps whilst Katrina's doing that, just to let you know that we've had some meetings with the Our Voice Forum that is led by Liam and Beth, the experience and involvement leads, and also another group comprising our service user governors to really sort of think about our strategy and how we can work together to take it forward. Now, what you can see here, firstly, if you look at the blue boxes, is the areas that we think that we will focus on in the new strategy. It's really important to try and create achievable objectives, and that means to focus on some key priority areas rather than being overly inclusive. So through various exercises and discussions, we've identified that areas we'd like to focus on in the next round is substance misuse, culture and language, with the aim of challenging any exclusion culture and really thinking about the language we use, family involvement, and gender. Now, initially, we called this men. As Carl said earlier on, it's really important to be thinking about men because suicide is 3 times more common in men than it is women. However, when we took this to the service user governors and additional service user representatives, there was some really helpful discussion around actually should we be talking about gender, and so within the gender context we will focus on men and male suicide that needs that attention, but also some of the other important issues to consider, such as younger women with complex presentations, including personality disorders and possibly substance misuse, and also the more gender fluid populations. You know, how are we supporting those groups and what improvements do we need to make. So already, by collaborating well with our service user population, we've improved where we, our objectives. And that actually was what brought culture into the language objective as well. So we've got our strategic steering group that will also have service user representation, probably via the governors, and then the reference groups will be much bigger groups that will be able to invite a lot of people to express their views, their perspectives and their feedback as we go through our sort of strategic process. So I'll stop there. And we will continue to update you on our strategy over these webinars potentially, but really over the next 6 to 12 months. And any questions, you know where I am, please get in touch with me. Thank you. I will pass back to Carl.
So I encourage you, for any questions from today that's been sparked, please let us know. Just go on to chat and ask any questions and we'll try and moderate that. As you've heard today, we've covered quite a lot of information in a relatively short space of time. I suppose the big things for me is just noting the scope of why this is so important, and Keith has given us an update from the Office of National Statistics. So just to give that reference, just to make sure anyone joining new has an idea of the context, it's something like 5,200 plus suicide people died by suicide in the last year. So that's over 5,000 people who've just give the context around England and Wales. And I suppose just again trying to just think about some of the myths that we're trying to make sure that we're able to communicate as an organisation externally to ICS and wider. One of the myths is, just to give you an idea from the ONS data, London has the lowest rate, as again, repeatedly over a decade, has the lowest rates of people dying by suicide. So just one of these ideas that it's a very complex picture, but at the same time, places like inner cities and places with greater deprivation do tend to have a significant increased rate or parity of rate in terms of deliberate self-harm. So it's just really important that people who are interested in making a difference to the population we serve really look at things within a wide spectrum of the people that we see, but also the population that we don't see, who we can actually make an influence on. And that talks to where Karen's come into in terms of our strategy. We see beyond some of the work that we're doing, fantastic to hear about the safety planning work, about our electronic records, having something that makes it much clearer about how we formulate and make an intervention. But also, we also heard just now about the increased need for family liaison and working with those individuals, those who are infected. And remember that for one person who has died by suicide, that affects those people who are part of their network, around 130 to 140 people affected. So it gives you an idea of why this is so important, that we keep on intervening and actually supporting a wider network from the individuals that we are seeing within the healthcare systems. So just great to sort of take that overview of where we are today. Also, we have, as an organisation, a greater emphasis on our staff well-being. So not having knowledge about women who are working with us, who are within our wider ICS, who have a greater rate, as presented above national rates in terms of female nurses. It's very important for us when we think about our offer for well-being and staff well-being hubs, that we are able to intervene or to focus on some of the areas of intervention and support. I've given you a little bit of a overview. The last thing I want to say is we have I think Keith and Karen have both referenced the National Confidential Inquiry in terms of how we think about the bigger picture and how we can make changes and intervene. So the National Confidential Inquiry, led by a team in Manchester, sends out questionnaires to organisations who, when someone has died by suicide, send a questionnaire out to NHS organisations, and some of you on this call today would have been contacted to support the questionnaire. It does take some time, but that questionnaire gives a very insightful, almost forensic understanding of that individual and the care that they received. For example, lots of individuals that we see who end up taking their life by suicide or dying by suicide are noted by the clinicians at the time to be low risk, and that comes from information from the National Confidential Inquiry. So I just want to encourage individuals within Oxford Health, if you've been contacted, please try and fill out the questionnaire. I know I've been contacted by the Manchester team saying that Oxford Health has a lower rate than the rest of the national response rate. It's something like 85%. We're responding to those questionnaires. So please, let's try, if you get anyone on this call today get contacted, please try and fill it in. It does make a massive difference to the future. So Karen, can I hand it back to you now to host Q&A, if I may? Thank you.
You can, yes, thank you, Carl. So we've got a few questions. The first one, I think, is well, it's in relation to remote working, and the question is there any evidence that seeing patients face-to-face versus remotely, especially by phone, helps reduce completed suicide, or the reverse? I'm concerned many GPs and other services are only speaking to patients, and this could limit effective risk assessment. So Keith, I wonder if I could pose that question to you in the first instance, please.
Yes, sure. Well, I'm not sure I'm going to be able to greatly, clarify this. It obviously has been a considerable concern about the change in provision of health. Karen and I have been involved in some work on what we call COVID-related factors that influence people who are presented with self-harm, particularly to the John Radcliffe Hospital. And one of the things that cropped up quite a lot initially was change in availability of services. In some cases, it was actually removal of services, but for some people, it was lack of face-to-face contact. And it was felt by the clinicians after interviewing patients that this had actually contributed to their self-harm, which is obviously very, very concerning. Now, whether that was a transient, an early impact of the pandemic and the things have settled down more now, I don't know. I don't know the answer to the question about whether online versus or face-to-face versus online working is preventive. I don't know of any evidence there, but I think many of us feel that having a face-to-face contact with someone, at least initially, can greatly assist subsequent interventions, be they face-to-face or online. In other words, having a face-to-face contact and having that extra interaction that always goes with face-to-face involvement can contribute to a better relationship that may facilitate online working subsequently. But again, that is an impression that I've heard people say, and I certainly makes sense to me. But I don't know the answer to the specific question, but those are some thoughts about relevant, relevant aspects of it.
Thank you, Keith. And I think certainly in relation to suicide risk assessment, a lot of the learning that we've had is we need to have that good depth of dialogue around talking about suicide with people. And sometimes I think that can be more challenging over the phone when you can't see somebody and their responses to your questions. However, in our training, we've built on some work done in the States where they develop core competencies for their suicide prevention line. And so their competencies are based on Joiner's model that a lot of you will be familiar with. And so it encourages us to look for suicidal desire, suicidal intent, suicidal capability and protective factors, and gives some prompts. So we have developed a poster that some teams will be familiar with. And actually what I'll do is I will make sure that that's available with this webinar on the intranet, and would encourage teams to have a look at that, because the more that we do telephone assessments, and if things become more difficult over the winter months, we might be doing again more of those. They might be helpful. There's another question around, are there any common causes for suicides in the nursing field? Keith, is that a question that you're able to answer? I know we're hoping to find some answers for that.
Well, we did a study many years ago now. We were commissioned by the Department of Health to do a national study on suicide in female nurses. This is going back well over 20 years. And in this study, we interviewed, we looked at medical notes of nurses who died by suicide, coroner's records, and we interviewed family members or other informants of nurses who died by suicide to try and build up a picture in each case. And obviously mental health issues were a major factor, particularly depression. Interestingly, at that time, a particular antidepressant, one of the old tricyclics, was very frequently used in those in the suicides by self-poisoning. And interestingly, at the time, there was a sort of belief that this drug prescribed in low doses was quite good for helping sleep and making people feel a bit better. My suspicion was that it was being prescribed quite widely to nursing staff because of sleep problems, which may have been reflecting depression, but not in sufficient doses to treat their depression. But on the other hand, it was very available as a toxic method of overdose. Another major problem was substance misuse issues, particularly alcohol misuse, and of course family problems, and to some extent work problems, particularly problems such as bullying and so on. And one common factor, I know Karen's got particular concerns about this, is when nurses are subject to investigation or other events concerning patient care, which sort of put them in public limelight, may lead to feelings of shame, possibly, and hopelessness. So those sort of events can be very important, and the same applies with doctors. So we know that there are quite a lot of doctors, suicide in doctors occurs where people are subject to complaints and investigation. Certainly, the General Medical Council has improved its practice, having recognised this in doctors, and I think operates much more sensitively now and in a supportive way that hopefully has reduced that risk. I'm less aware of what might have happened in relation to the nursing profession.
Thank you, Keith. Well, we have got a couple of other questions, but I'm not sure we've got another couple of minutes, as I think we're due to close at 4:45, if that's correct. So with the other questions, what we can do is we can put them on the intranet with the webinar, and I'll give the questions to Keith and Carl and see if they would like a response. In the last minute, however, firstly, thank you for joining us today. Thank you, Keith, and thank you, Carl, and thank you, Katrina, for being there. We can see here, you can't, but she's done the slides and set all of this up, so thank you for that. Next week, we're inviting Chloe Beale, who's a liaison psychiatrist who's written a paper called Magical Thinking and Moral Injury in Psychiatry, which talks about language and culture. And Linda Thompson, who is a peer support worker working with us in our crisis team in Oxford, who are going to talk together about some of the language we find ourselves using sometimes in mental health and perhaps the reasons for that. And subsequent webinars, one is focusing on mental imagery in young people, and another, which Rory O'Connor is coming to talk about his integrated volitional motivational model of suicide and the importance of safety planning. So it'd be great if you could continue to join us for our subsequent webinars. And once again, thank you very much.